always involved in workshops, symposium, and takes active role in the different pain conferences. He will be covering indications, contraindication, complication, insertion techniques, intrathecal components, what are the components and the drug use, and of course the follow-up and the complication. The coordinator for today's are Dr. Kashinath and coordinator for this thing, this moderator for this session. So over to Dr. Ashu Jain, please.
Thank you, sir. Thank you so much. So today we will talk about a very important part of our pain medicine, and everybody who is doing will agree that this is one of the most rewarding procedure in our pain medicine. And this is amongst the procedure where you can get almost 100% results if your indications are correct. And very rewarding for the patient, very rewarding for us. So we will. So what we will discuss today, we will discuss history, introduction, method of intraspinal drug delivery system, what are the other methods. Particularly, we will talk about implantable intrathecal infusion pumps. Then how we select a patient, which is most important. Then it has to undergo first trial, then implantation, then how to refill and program this. This is very important. What are the expected complications? What medications we can give, and what are the new pharmacological agent that are in use. So if you go into the history, this is a very started. अरे क्या हो गया यार? I think there is some. Am I audible? No, there is some problem with the screen.
Yes, yes, you are audible.
But my screen is pop up. भवेश आइए देखिए, चेंज होस्ट आ गया, ये इसको कैंसिल करें.
Someone is requesting to be a host.
और इसको वो कर दे मिनिमाइज. कर्सर आ नहीं रहा ना. जस्ट ए सेकेंड. हाँ, इसको मिनिमाइज कर दे एंड इसको मैक्सिमाइज. प्ले.
Should be okay.
Okay. So so it started way back in. Am I audible?
Yes, yes,
Yes,
yes.
okay.
Please.
So it started way back in 1898, but the first programmable implantable pump was seen in 1981 only. So it take almost 90 years from a demonstrable of intrathecal cocaine for limb surgery to programmable intrathecal pump. So it's a important thing. And let us start with the introduction. This is the pump which is now available in India. This is the only pump which is available in India right now, Medtronic Synchromed 2. So what are the advantage of giving intrathecal drug versus systemic delivery? Why intrathecal drug is recommended? Because we directly infuse the drug intrathecally. The low serum blood levels because of intrathecal placement, and the dose that we give in intrathecal route is almost 1/100th of the systemic dose. So doses are very low, and that's why their systemic side effects are negligible. Whereas any other system which are giving IV, you have exactly opposite to what we are getting advantage here. And then again, if we talk about intrathecal versus epidural delivery systems, intrathecal has much faster onset, as you know, as compared to epidural drug delivery. And again, the dose of intrathecal is almost 1/10 of the dose of epidural. So their systemic side effects are very less as compared to epidural drug delivery. So for patients who are for long-term infusions, intrathecal is much better than epidural infusion systems. And that's why the epidural infusion systems are not in place too much. Now, there are two, three kind of system. One is externalized system where, everything is external, which we usually do. The catheter is external and the port is external. So these are for the short duration of time, 5 to 7 days maybe. But otherwise, because there is a very high risk of infections that we are doing in anesthesia, then they are partially externalized system where you can tunnel the catheter, and but the drug delivery system is outside. This is probably done in onco patients where you need it for a duration of weeks. You can use this, but if you require it for a longer duration of time, both catheter and pump system are completely internalized. So there is nothing outside, and you have to refill the pump inside the below the skin only. And they have the greatest advantage, but they are very expensive. And unfortunately, in our country, the insurance companies, they don't cover. So this is the issue with them. And then if we go to the type of implantable pump, there are two kind of implantable pumps. One is for fixed rate duration. They are non-programmable because they can either deliver 1 ml or half ml per day in 24 hours. They are without batteries, and they have pressure gas chambers or elastomeric membrane, and they have a constant drug flow. So if you want to change the drug, you have to refill the pump again. That is their biggest disadvantage. But what is the advantage? They can work for life. You don't need to change them, and they are much uh, cheaper as compared to programmable pumps. But I have done earlier these non-programmable pump with very good results. But now, unfortunately, they are again, we are finding it hard to get in India. And the only pump right now available is this programmable pump from Medtronic. And this is the pump where you can change the rate and the dose and everything by program, as you are doing for spinal cord stimulator, or you are doing for these kind of devices. So this was the earlier Codeman's 3000 fixed days infusion pump. This is not available. The available pump in India was Tricumed from Germany. Uh, that is, we are finding it difficult these days to import. And then this is the one that is presently available in India. You can see there is a pump. We will discuss about the component later on in the discussion in the class. So they are you can do everything with this programmable pump. You can give patient controlled intrathecal bolus through a remote control device. You have a peristaltic roller system to move from drug from reservoir to implanted catheter. They are available in 20 and 40 ml depending on the which drug and how much concentration we are using. And they are approved for only baclofen, morphine, and ziconotide. In India, ziconotide is not available, so we are primarily using them for baclofen and morphine only. Depending on the indication, we will discuss now in the subsequent time that when to use morphine and when to use baclofen, and or in combination. So that is mm, their use. And the membrane where we refill it is, it's a very high quality membrane, and you can do 500 punctures. And these pumps, they need to be refilled almost once in a year. So they are very good for the uh, uh, duration of life of the patient. But the problem is with the battery. Within span of around 5 years, their battery goes down, and we have to change whole of the pump, barring this catheter. And that cost almost the same amount as we are just 80,000 less, the same amount that we are spending now. So that is the biggest disadvantage, because we have to see affordability, that patient should be willing to spend that much of money. The cost is right now is around, I think, 7.5 lakhs, and it is huge cost. to the patient, and they should be ready to spend it every 5 years. Then surgery expenses are more top of that. So it's expensive stuff, and while we are selecting our patient, we must talk to our patient about the duration of the life of the pump, because it is not a one-time phenomenon like tricumed pump. It is a thing that has to be changed after every 5 years almost. And if your infusion rate is high and you have to adjust it again and again and give boluses, probably the life can end, battery can end before that also. So these are the intrathecal pump. So they are not available in India now. These are fixed pump. There is a valve which allows a constant flow of drug, fixed amount in 24 hours, but they are not available now. So what is the evaluation of the patient before we select a patient for intrathecal pump? So it depends on it is useful in both the cancer and non-cancer pain. In cancer pain, particularly, I would say recommend the patients who are cancer survivor and they have severe neuropathic pain and their lifespan is well, their disease is now inactive. They are probably the most ideal patient for these kind of intrathecal pump, and we have seen the results in these kind of patients. And though in this here it is written life expectancy more than 2 to 3 months. No, it is not correct. It should be more than 6 months to 1 year, because you are spending almost 9 to 10 lakhs rupees for less around 2 to 3 months of life expectancy, which is not good. So particularly, as I told you, it is good for patients who are cancer survivor and have after the surgery or chemotherapy and whatever they have that kind of pain, but their cancer is in control. They are the ideal patient, but if their life expectancy is good, you can use them. Then we come to the non-cancer pain, where it is used nicely, particularly where the and once you implant take decision to implant these devices, you should have failed all conservative therapies, either it is drug trial or RFA or any other therapy that you can do, because these are costly alternatives. So you should be very careful that you don't choose this therapy straight on before failing with other cheaper therapies. Then the neuropathic indication, spinal cord injury, we will show you the video that in a patient with the spinal cord injury with severe pain below the level of lesion, and it's a severe pain around the 24 hours, and patient's life is really bad, and we have recently done this patient 4 months back and with a very good results. Then diabetic peripheral neuropathy, CRPS, here the role of intrathecal pump is slightly debatable. The results are around 40, 45, 50%, and various combination have been tried in CRPS. We can talk in detail about that. Then uh, uh, post-herpetic neuralgia and all these kind of thing, failed back surgery syndrome is a very good indication, uh, particularly in patients who have gone repeated surgeries and surgeon says that they have nothing else to offer. This is a very good choice, intrathecal pump, in comparison to spinal cord stimulator. Then patients like chronic pancreatitis. Then if you have a patients like chronic vertebral compression fractures and severe spinal cord degeneration, you can also use this pump there. But if there is a nociceptive pain, the role of pumps are slightly debatable. So if you can correct the lesion first, if you can correct the vertebral fracture first, or you can correct the spine first, that is should be the correcting the deformity should be your priority rather than putting the pump. But if somehow it is not feasible, then of course you can try this therapy. Now you have various evidence for RCTs and so many studies where people have demonstrated the efficacy. But if you go into the detail and see this table, the efficacy reports, success rate depend varies from 37 to 74, sometimes 93%. So it's variable depending on the patient. So many factors are playing. So you can't say that all the patient who will be implanted in the thicker pump, they will have benefits. So for rule out those population, you must do trial first. We will talk about that. You must not implant intrathecal pump without having a good trial and demonstrating the efficacy of intrathecal morphine or baclofen in our setup. And if you have good result with trial, then of course intrathecal pump is the answer. So this is about that. And then about discontinuation of the blood thinner, as you know, they are standard as per we are using with other procedure with clopidogrel, antiplatelet therapies, and all these therapies. The duration for stopping the drug is the same as for other therapies, so it is not different. Then this is most important, whenever you are implanting any permanent device into the body, you must rule out any ongoing infection in the body, because that infection can go and seed on the pump, and once the device catches the infection, it doesn't go. So what is the standard protocol? If you are have done trial and you are looking to implant the device, either spinal cord stimulator or intrathecal pump, you must have done urine culture, blood culture, throat culture. Urine infection is something that is very regularly causing these implantable device infection. So you have to treat all those infection in the body first, and only then you can implant these devices. That should be your standard protocol before you go on and implant their devices. So any active and chronic bacterial fungal infections, you can't do this. Then if as I told you, pump pocket infection is deadly. You have to implant the entire pump with catheter system and make the patient infection free before trying it from the other side. Then if patient is having other diseases where their sensitivity to other depressant effects of opioid and CO2 retention, but as I told you, the doses are so less, this should be a relative contraindication. And all these patients should be done carefully. Then smoking is said that the smokers, if they can cause your increased risk of infection, so smoking should be stopped 2 months prior to the intrathecal pump. But this is again a relative contraindication. Now this is most important thing, psychological screening. uh, as you know, the chronic pain has a lot of central sensitivity and emotional and psychological component. And this should be a standard protocol that before you implant any implantable device, you should take clearance from psychologists that or psychiatrists that they are okay, because any psychological issue is absolute contraindication for implanting a device. Because similarly, the drug abuse, if patient is on drug abuse, you can't implant intrathecal device. So this is an absolute contraindication for implanting a pump. So you should be very careful about infection. You should be very careful about psychological and drug abuse and their psychological behavior and condition and their dependency on that. Now, the most important point, what are the optimal candidates for these drug delivery systems? So this should be a chronic, severe, intractable pain that has not been responsive to less invasive form of therapy. So exactly this what I was trying to tell you. Since it's a expensive device, and and it has got its own complication, you should exhaust other less invasive therapy first. Then the uh, ability to understand the process of implanting an intrathecal delivery system. The patient and family must understand what we are doing with them. It is not like that you have just implanted the device and then don't know how to take care of this device. So this is important. Then adequate expectations and possible outcome of the procedure. So this is important. You can't tell them that this is a magic wand and you touch it and everything will be all right. And that's why always before deciding for implant, you should do uh, trial first. So that is important. And as I told you, no significant treated psychological disorder. This is very, very important. And then we must not forget that this device requires a constant follow-up in your office and evaluation for post-implant maintenance and surveillance, because you may have to refill the pump. There can be other problem with the pump, so patient should be ready to do that. Now suppose patient is living in the area which is inaccessible, that is one of the relative contraindication for putting those devices, because if there is nobody around him to take care of these devices, this can really make their life hell. So should be very careful about that. And as I told you, no active substance abuse and dependence should be there. And we have already talked about local sepsis or UTI and any other sepsis, and chronic anticoagulation should be careful, because that can cause serious hematomas in the CNS. So that is a important thing. And then we must not forget that there should be economic, social support and economic support system, because as I told you, the duration of the pump is not more than 5 years, and it costs around 10 lakhs every time after 5 years, when we are going to change the device, because unfortunately battery is not separate, you have to change the device as such, and it's a costly stuff. So you should be considering all these things into parameter, because the insurance is not available and the panel is not giving that much of money. They are giving just 2 lakhs, 2.5 lakhs fixed amount. So most of the patients, they are not affording. So if they can't do it again after 5 years, there is no point in doing that. So this is important. Then uh, as I told you, we have to do the trial first to prove the efficacy of the drug delivery, that intrathecal drug will be helping the patient. Only then we have to do the uh, implant. So this is done by two methods: single bolus intrathecal injection and continuous intrathecal infusion. It should be, if you are implanting an intrathecal device, it should be not epidural infusion, it has to be intrathecal infusion, because you can replicate the dose in that case. So but for doing continuous intrathecal, though ideally it is the best way to go, and you have to put the intrathecal catheter for 3 to 5 days and give continuous infusion to see, because it will actually mimic the your intrathecal pump. But patient has to be admitted in hospital, putting the intrathecal catheter and keeping the patient for 5 days is again, uh, can be costly, and then can related to infection and all these. So but if you can do this, this is the ideal mechanism. But otherwise, uh, just doing a single bolus of dose, like if you are giving morphine, 0.5 to 0.6 mg of morphine single dose intrathecal, if you are doing baclofen, then 50 mics of baclofen intrathecal or mix, single bolus, and then reassess the outcome after 24 hours, and then you can do the retrial. And this method is equally uh, effective as your intrathecal continuous trial. So there is no study which will prove severe superiority of one trial over the other. So we in our practice are doing bolus intrathecal all the patients, and we have been very successful with this method. And patient likes that, because it is done on daycare basis, same day they go home, and we can get the result that we want to. So this is what. And though there are some guidelines that it is not required for patient with advanced cancer patients, but in our setups where they are costly, probably doing trial for this patient is important. Now, if you are doing it for baclofen for spasticity, you must involve, like we involve our physiotherapy department. Uh, you have to do intrathecal baclofen injection or continuous infusion. So continuous infusion, you will start with the 50 mics, and then depending on patient's response, you can jump by 25 mics, 75 mics, and so on. But we are doing a single injection of 50 mics, and then hourly you have to do modified Ashworth scale for spasticity, and these are the scale, and your goal is to keep your patient in at least 1 or 1 plus. Suppose the initial spasticity score is 4, then you should not bring it below +1 or 1, because you don't want flaccidity. So your score should decrease by 2. So it is 4, it should come at least by 2 or 1, and that is your ultimate goal. And if you once inject intrathecal baclofen, it takes around 6 to 8 hours, because the effect will peak in next 1 to 3 hours and then fade away from 6 to 10 hours. So what we do, we admit our patients in the daycare, and then in the morning we start doing this trial, and by evening we know that after 3 or 4 hours that what was the dose we have given, suppose 50 mics, and how patient is behaving. If the score comes from 4 to 2, that's okay. That means we can start with 70 or 75 mics of intrathecal delivery system. We don't do another trial. If it doesn't decrease below 3, then definitely in next day you have to increase the dose by 25 mics and go with 75 mics trial. So and if this is important, your patients are on high dose of opioids before the implant, then definitely you have to decrease the systemic dose of opioids. Like my patients with the spinal cord injury, he used to have for 2 years on heavy dose of tramadol. So for 2 months we put him on tramadol to triadecontin for SR, slow release tramadol, decrease its dose in 1 month to from 300 milligram to 100 milligram, then to 50 milligram, and once patient was uh, stabilized on 50 milligram per day, then we thought of implanting the device. So this is how you have to do. You have to decrease the dose of opioid, otherwise it will land into failure. now now you have done the trial, your trial is successful, and now you want to implant the pump. So where you will implant the pump? So usually intrathecal pump is implanted in left or right lower quadrant of the abdomen, because it is larger than size, much larger than size as compared to your spinal cord stimulators. So you can't implant in front of the chest. The best place is this right or left lower quadrant of the abdomen. You have lot of subcutaneous fat over there, so your device is not palpable over the skin. And then secondly, it can accommodate that device. And second important point is the pump should not go below the belt line. So it should be above, the pocket should be such that it is above the belt line, otherwise the patient can have problems. And you should see how much is body fat there is any surgery scar or infection, poor skin texture, and it should be away from bony prominences. That means iliac crest and ribs, you should a device should avoid rubbing. So that is the ideal quadrant where you will implant. Then there is prophylactic antibiotics, and as you the as standard cefazolin 2 gram or 3 gram more than 120, and in follow up we can give this 3 to 5 days antibiotic orally. And anesthesia for trial is no anesthesia, but for implantation usually it is done in general anesthesia. And I'll show you the patient first, one of our patient. This will give you insight about the effectiveness of this procedure. And then I'll show you the actual video of our last patient. It is a 7 to 8 minute video where it will explain every step. So just I thought before giving you just slides will not help you. The beginners one, like our fellows, they can have a fair idea how this setup is done and how this is implanted. So kindly bear with me. It will be around 7 minutes video. It nicely explain about how the intrathecal pump is implanted. So see the patient. Now see, this patient has intramedullary tumor at T6. She was operated, and then she after the procedure surgery, she landed into this cross paralysis with severe spasticity and pain. And see the condition of the patient. She is crying, and she came to us after 5 to 7 years of her condition, and she had severe infection in the groin that was also treated. And see the kind of pain and spasticity, the life of the patient and quality of life if the patient is held. Now the same patient, after we implanted intrathecal morphine with baclofen 0.6 milligram of intrathecal morphine with 50 microgram of baclofen exactly after 24 hours. See the same patient, no pain, patient is comfortable, legs are open, no cross spasticity. So this is what your intrathecal pump can achieve. And this is now almost pre-COVID, and the patient is doing wonders. So this is how, when we implanted the Trichomed pump those days, it was available. So it's a lifelong pump. So she gets refill it in Baghdad, and the patient is happy. See, patient is absolutely happy. No spasticity, no pain, right? So this is what your intrathecal device can do. Legs are nicely opened. All the spasticity has gone, right? So this is how it works. Now I'll show you the videos, and I humbly submit that this is not for any promotion. This is the video that I shoot for teaching our students. So I'm playing this video. It is 7 to 8 minutes video, and it explains every step about our intrathecal pump implant and how you program the pump. Kindly bear with me, and all the new students, they will be highly benefited.
This is a patient of spinal cord injury, and patient has severe pain below the point of injury in the legs and in the lower back. And this is a post spinal injury pain and not responding to any medical management. Today we will do intrathecal pump implantation, and we will do it with the morphine. This is the position of the patient. It is in left lateral position. We have exposed the back, and patient is nicely under general anesthesia, and the patient is nicely secured in the position. Now we'll do cleaning and draping. This is a puncture needle. We will puncture, go into intrathecal space with this. Then this is the catheter with stylet. We will introduce the catheter into the intrathecal space. And this is the catheter which will go to the pump. This funnel shape area will go to the pump, and this will go to this catheter. So these are the part of catheter for intrathecal pump. Now we are taking out the guide wire. Now we'll take out the needle. Now we'll see drops of CSF into this. Can you see drops of CSF? Right. Now this is one butterfly that we want to fix it. Okay. This is the pump. This is the port through which we fill the drug. This is CSF port. And this is the point where we will connect the catheter from the pocket. These are the 4 anchors at which we will fix the pump in the pocket. CSF, it is trickling down from the other end, which will be connected to the pump. That means this is connected to intrathecal catheter here, and CSF is dribbling from this port. Now we are going to connect this end to the pump. Okay. Now this is connected to the pump. Pocket. This is now front. It is nicely anchored at its place. Now we close this pocket and this is off. So now we are starting the programming of pump. So we have given the morphine injection with diluted dose 7.5 mg per ml. Next part is reservoir. How much we have refilled the pump? We have refilled a 40 ml pump. Next is infusion. How much we have giving the drug rate per day? So 0.79 is almost 0.8 mg per day he will receive to the pump. Next, we have started the bolus. So 0.258 ml will be refilled in the catheter. And within a 16 to 15 minutes, complete catheter will be filled with the bolus. Next. And now we have set the alarm. We have complete the pump with 40 ml pump, and when the pump will at 2 ml, it will give the alarm, and every 10 minutes. And once it will below 2 ml, it will give the critical alarm every 10 minutes. And before 2 ml, when it will come near to the 2 ml, that it will give the every 1 hour, it will give non-critical alarm. But when it will go down below 2 ml, then it will give critical alarm every 10 minutes. Next refill date is around 350 days, 353 days, almost 6th of December 2025. Next, let's finish.
So I hope you might have understood all the nice steps. So I'll be just now explaining these steps, like patient preparing and positioning we have already explained. And usually when you are trying to insert the Tuhi needle, and if you have place to go, you should insert at around 30-degree angle. You should not, your catheter should not enter the spine at 90-degree because it can bend there. So it is important that you may start, if you can get a place and space 1 level below the point of entry. So this is how, and this is done paramedian. So that is about this. You can see the needle is starting at 1 level below, going up, and then it is a catheter. Usually minimal you should have 2 level above the point of entry, and there is a complication called catheter tip granuloma. So if you can keep your catheter below L1, that is of great help, because there is cauda roots there, there is no spinal cord. So the complication related to catheter tip neuroma, they are less. So if the lumbar area is available, you should make your entry around L4, L5 and go up to L2, lower level of L1 where there is the cord ends. That is how it helps. And if you have to go above, then you can't help it. So this is, we have already explained all the steps in our this video, and this is what everything we have explained, how to fix a butterfly and do that, and making a pocket. Your pocket should be around 4 finger, and the depth is from tip of the finger to the base of the finger. That should be okay. And then uh, the point of the I'll explain about the pump in then this is tunneling, and this is how we have explained everything. Now look at the pump picture. Now there is a central refill membrane port. The port is in the center. That is for refilling the medicine that you might have seen in the video. I was refilling the morphine into the pump. Then there is a port at the tip of the pump, that angle of the pump in front above, that is for CSF port. So your catheter is connected at the CSF port. These two ports are different, and this angle, the CSF port, when you are inserting the pump, it should go towards the pubic symphysis, so that this the lower part is towards the ribs, and you don't while you are refilling, you don't enter into the CSF port, because if you inject your drug into CSF port, patient can die on table. So you have to be very careful, and everything I have explained. And while you are fixing your pump into the pocket, the catheter that you wind around, it is a long catheter, you should not cut that. It should not come in front of the pump, as I was explaining, because when you are doing puncture, if it is in front of the pump, you can go through the catheter, and you can end up with pump failure. So while your catheter should be winded around the pump, and it should be slided below the pump, so it should not be present below the skin, so that while refilling it should be okay. I have explained it in that video, and I have shown you these drops coming out of the catheter part, and then it is refilling, implanting into the device, into the pocket. This we have explained, and small suture and butterfly in the back, this we have done. And this is about the refilling, which is again very important. While during refilling, like in a new pump also, if you have noticed in that video, there is always some fluid inside the pump. You should suck out that first. Same applies when you refilling the pump. You should take out the leftover medicine. So when you place your programmable device over the uh, pump, it will tell you about the remaining volume of the drug, and while you aspirate, it should match. Suppose that your device, your tablet is telling you when you open the program that 10 ml is left, and you can only able to aspirate 2 ml, that means there is something wrong with the pump. Then it's a serious issue. But if you get around 8 to 9 ml, that's okay. So whatever volume the device said, it should be matching with your aspirated volume. Then while you are injecting your drug, you know, you should not inject air. It can cause air lock, and this air lock can uh, can stop delivery of the drug to the intrathecal space. Should be very careful. They are like you use in epidural catheter, they are the filters which can entrap air, and should be careful. If you don't get filter, please use three-way in between the pump and the syringe, so that you can two-way take out the air from the pump and the syringe, and then only after that you are sure that there is no air into the system, you should inject the drug. And the needle is also should be hypodermic needle. You can't puncture your membrane with a sharp bevel needle, because it can cut the membrane, and you can land into failure. The drug will come out because it is under high pressure. So your needle should always be hypodermic needle. And there is earlier there was a kit available. Now unfortunately Medtronic people, they are not providing this kit. It was previously available in the market. I don't know what is the problem. Then in that case, you should make this extension, PM line extension. You should have a 3-way, then you should have a 20 ml syringe, and then hypodermic needles are available in the market. You should use it once and throw it out. This is how you have to do this. So this is how your needle goes. If you see in the central port, it is for drug, and in the front, which is for the CSF. So should be very careful. If you are not, it is slightly projecting so that you can feel that membrane under the skin. You can see this is projecting. But if you have any doubt about this, you can use ultrasound, and there are also locator of port locator. You can use that. But mind you, if you inject morphine or baclofen into the CSF port, your patient is going to die on table. So we have to be very careful while doing this. So these are the final pictures as you see, and this can be very nicely done under ultrasound also if you are not confident about locating your pump. So this is how there is a device which is kept over the pump, and then other part is to the tablet. Now these days the tablet can directly connect with the pump, so you don't need that. So that is okay. And this is how, I have explained refilling. And now coming to the complication. So immediate bleeding, hematoma, infection. So these are the CSF leak, neurological injury. These are the important this thing points. So whenever you finish your procedure, always give a pressure dressing for 48 hours with the uh, uh, compression bandage, so that there is not any hematoma and seroma formation, and should be looking for the same for next 10 days to 2 weeks time. And it is the time when you say your patient from around 4 to 6 weeks not to do any aggressive movements or aggressive exercise, because your pump is not fixed by that time. After 4 to 6 weeks, the adhesion forms, and then it becomes uh, okay. Then there are device related complication, where it can be catheter fracture. As I told you, it should be straight, should not be at 90-degree angle. Puncture, you can puncture the catheter, disconnection, migration, battery failure, pump rotator failure, in failure of temporary electronic modules. If these happens, battery failure, pump failure, company replace it for free. But these are important things, so that your patient needs constant monitoring. Similarly, uh, you can have catheter granuloma, as I was talking about. So if you can enter from the lower lumbar area and end up your catheter below L1, that will be great. And this granuloma, particularly when you are using multiple drug and high dose infusion, there it is more common. So these are the medications you can use: morphine, ziconotide not available, baclofen. These are so usually we use morphine, because in smaller dose you can have a good effect 24 hours. So only we use morphine intrathecal, rest all is usually the 0.5 to 1.2 1.3 milligram per day is good enough. That is the thing. This is the picture showing the catheter granuloma. So this is how, like in MRI also you can see there is a granuloma sitting over there. So this can happen. And then ziconotide is not available, so we are not talking about too much. You can read it yourself. Then baclofen, yes. Baclofen is a very good drug for spasticity, as I've shown you video in my patient. After 24 hours, patient is absolutely comfortable. The only thing with the bupivacaine is, with the baclofen is you should be cautious that it suddenly should not stop flowing into the system, because it can cause serious complication, cardiac arrhythmias, muscle lysis, and all these. So you should be very careful that intrathecal baclofen is flowing. It is not uh, uh, stopping all of a sudden. So continuous monitoring of the patients is important. So this is what I think we are finishing with this. So we are almost done with this. Other drugs we are not using, so I'm not talking about that. You can read it. So most of that thing I think I have covered. So what are the take-home messages? Intrathecal pump is a comprehensive knowledge of process is important, including selection of the appropriate patient is most important. Indication, as I told you, is important. Then trial followed by surgical procedure, implantation, and which drug you want to use. As I told you, two drugs are available, so we can use them: spasticity, baclofen, pain, morphine. Both spasticity and pain, as in my patient we have used 0.6 milligram of morphine plus 50 mics of baclofen, so you can use in combination. So then this is important, and you can use in both intractable cancer or non-cancer pain, and they are if used judiciously, uh, there is a consensus that yes, it helps you. Thank you so much. Thank you.
Thank you, Dr. Ashu, for excellent presentation. I think it was very elaborate, very simplified. You showed the video also practically how it is done, so that the students can benefit in exactly what is
Yes,
the
sir.
how the procedure is being done. And you have really
Sir, your
in
connection.
detail, in fact.
Hmm.
There is a question from Deepanjali,
Yes,
who is
sir.
asking, what is the difference between catheter access port and catheter port?
Sorry,
What is the difference between catheter access port and catheter port?
I didn't
That's
get
what
the
she has
question.
asked.
What she want to ask, there is only one port in the pump, which is where we have to use that catheter, the funnel shaped area of the tip of the catheter goes there, and we tunnel it and connect it to the intrathecal catheter. So that is the only one port available.
Yeah, where the pump is connected with the
Yeah, it
catheter.
is
That is
only
the
one
catheter
port
access
available.
port.
There is no other port available.
There is no other port.
Okay, okay,
Second
sir.
thing,
Thank you.
I just want to ask you one thing.
Hmm.
Why we use preservative-free things when using
Sir,
intrathecal drugs?
there is a huge debate over this.
That is for students to know, in fact.
Because uh, in previous year, particularly with this Metronic pump, which have gears and all this, uh, these there have been reports of pump failure with drugs with preservative. So FDA, after those reports, there was a huge controversy in US where they have banned this pump for a quite couple of years, and then the latest recommendation came that you come up with you inject preservative free drug. It is not a issue with the trichomet pump, which is we don't have motors, but with this devices, that was the issue, and this was a serious issue couple of year back, and now this has been resolved. The thing is you have to give preservative free drug.
Another question that is I wish to ask you is this thing for the students. Can, apart from morphine, baclofen, what is being used, can you use midas if the patient
Sir,
is
uh, there are reports that particularly in patient with CRPS and other indication, people have used, but
or
uh,
local anesthetic, by the way, local anesthetic, by the way.
local bupivacaine and midazolam. But seriously speaking, we don't have any experience, but it is mentioned in the book that you can use clonidine, you can use bupivacaine, you can use fentanyl, you can use midaz in different combinations. But experiences with these are low, and these are particularly combination they are used in these kind of neuropathic like CRPS, where the pump rate failure are very high.
I have used bupivacaine, very low dose
Hmm.
of bupivacaine that
Yes.
works in fact this thing. But
Huh.
sometimes the problem is of the pump malfunction is there. It's not
So
working
that is
properly.
the issue. The experience
That's
with
the thing.
bupivacaine and midazolam is low, as you know.
And what about fentanyl?
Fentanyl you can use. If you can refill it in appropriate time, you can
No
use fentanyl.
problem.
No problems. But I tell you one thing,
Okay, okay.
uh, the morphine is a hydrophilic drug, hydrophobic drug. So the spread of the uh, morphine in CSF is better than fentanyl. So if you want to use multiple segments, morphine is better drug you can use in, like I said, most of the cases 0.6 milligram, 0.5, 0.6 milligram in 24 hours. and you need not to screw your catheter to the level of pain. In fentanyl, you have to go to that level because it is a hydrophilic drug. It will go and stick there. So
So
if
segmental analgesia is with fentanyl, not with the morphine. It can ascend up.
yes, sir. Yes, sir. That is the thing. So morphine works wonderfully well. But some patients have like pruritus and all those kind of. One of my patient had serious pruritus, and I have to manage with the antihistaminics in him, and this can be serious limiting complication. Yes,
Yeah, have you ever used low dose naloxone if the patient is not getting all right with the
you can use, sir. You can use. You can use, sir. Yes, it is recommended.
One can
If
use it theoretically, but practically, I mean to
I
say,
have not
IV
used.
giving
IV
IV
naloxone in
naloxone, low
otherwise
dose naloxone.
in anesthesia I have used, but not in pain medicine.
Okay.
Hmm.
So there are not not many questions. I think you explained it so beautifully and simplified way. So thanks a lot. Thank you very much. Thank you
Thank
very
you, ji.
much.
So we can call it off.
Yeah, thanks a lot.
Thank you, sir. Thank you. Good night, sir.
Okay. Okay.
Thank you, sir. कौन सी हो रहा है ये?
Speaker, coordinator, and everybody involved in this thing. Thank you very much.
Thank you, ji.